the Dr. Sindhura for organizing such a wonderful program. And apologies for not turning up because I felt by the time I land in Vijayawada at 9:59, 10 o'clock, I thought I won't be able to make up in writing time by 2 o'clock for my session. That's the reason to request for Zoom call. And in this journey, I'll be taking you through what is happening in stimulation protocol and what we should know, how should we choose some of these protocols, and where is the role of them in these protocols. Over the years, when IVF began in 1970, the goal is to get one oocyte, and with time, clomiphene citrate came in, later gonadotropins came in, and subsequently the long protocol. Then in the late 1990s, or to be more precise, in 2000, 2001, that's the Antagon protocol has come in, and the whole field of reproductive medicine have changed. And in the last 7 years, we are again seeing another change is the role of dual stimulation, random start stimulation, and also the role of persistent prime stimulation. All these are making a huge difference. When you look at these stimulation protocols, the most important thing in any stimulation protocol is safety of the patient, getting adequate number of oocytes in the given cost factors is the consideration that should be taken, which makes a huge difference. The parameters that make a difference, I think I'm getting a resound from them. The parameters which we take, the AMH, the antral follicle count, and there is more than that, which I'll be discussing in the couple of slides. We are moving to an individualized response to stimulation protocol based on the AMH, the AFC, the age. But in our practice, what we do is we use the following parameters. We use the age of the patient. We cut them into different stratification, less than 25, 30, 35, 37, 39. Again, in the BMI, we subdivide them. And we also look at the AFC, well, between 9 to 16, 16 to 25, more than 30. We also look into the parameters, the parameters of the ovarian surgery and the immunological parameters. But before I dwell on to this thing, there is an important article which was published in the January issue of our Foxy journal. Untimely menopause, state-wise prevalence, and determinants, insights from longitudinal aging study in India, which was published in the January issue of our Foxy journal. And you'll have a couple of surprises when you look at the data. This is one of the slides, and if you look at this is where we are, and untimely menopause, state-wise prevalence, early menopause in Indian states, and we are falling into the red group, and the incidence is 20%. And premature menopause in the Indian states, where it is between 9.2 to 14%. Again, we are falling into the states. Is it the rice belt of India? Is it where major rivers flow through this part of this thing from north to south? And that's where we live in. Are we giving any attention to this? The scientific community looking into this major area, which we are seeing of less ovarian reserves and having difficulty in stimulation. Can this be prevented for the future generation? You can't do anything about the present generation, but we have a responsibility for the future generation. That's my plea to all the audience and to the scientific community at large. In this, I have reviewed and picked up 50 relevant articles to look at the guidelines to make this presentation. But before we go for that, the most important thing before you pick up a stimulation protocol is what is your optimal dosage? Even after 50 years of IVF, we have not yet determined what is the starting dosage, but I just want to share what we use as a starting dosage. Like I discussed, I use age as a criteria and then adjust the dosage based on the age. Similarly, I use the body mass index. I use the antral follicle count more than the AMH. And if the AMH is more than 5, I look for the testosterone, correct the testosterone. And I also look for comorbidities like psoriasis, collagen disorders, thyroid antibodies, which also alter the ovarian response. Whichever protocol you choose, start using a starting dosage, which will help you to optimize the stimulation protocol. It is the basic foundation on which you have to build your stimulation protocol. Whatever drug you use, start using a single product. Every product is good. It has its own benefits and disadvantages. But unless you start optimizing your dosage with a particular product, you are adding one more variable. Then let's discuss what's happening in different protocol areas. The conventional protocol was designed to give maximum oocyte yield, but it came with a cost of higher oocyte ovarian hyperstimulation and patient burden, and maximum oocyte yield with a morbidity is not acceptable. But nobody says it is banned. I repeat, long protocol has its own role. Antagonistic protocol has own role. So we use long protocol in normal responders and in low responders. But we don't use it in any patient whose AMH is more than 5 and whose AFC is more than 30. That's the criteria we have chosen. It's up to you to look at the literature and find an optimal protocol in your given practice. On top of it, we use this dosage regimen to avoid hyperstimulation. So without optimization of the dosage, just selecting a protocol will not prevent hyperstimulation or will not give good oocyte aid. Then when we move to antagonistic protocol, it is safe and a preferred treatment for high risk and for normal responders. But the trend I'm seeing is an antagonistic protocol is patient friendly, but that does not mean we should not do the due diligence of checking up the patient of what else problems they have. Only doing the pickup, fertilizing the embryo, and then looking at what problems are there, and then struggling with the endometrial preparation, that is sometimes sad to see. That is quite often happening. So if you are choosing an antagonistic protocol, it's a patient-friendly protocol, but do the due diligence of having a proper workup and then use the antagonistic protocol. Otherwise, we are putting ourselves into the criticism of we pick up the eggs, create the embryos, and then look at the endometrium. That's not a good thing to hear. As we move to the mild and minimal stimulation, these have a role, but in selected situations. They have comparable success rate of pregnancy rate, but it is not per oocyte pickup. It is per patient. Most of the time, when we read literature review, we should look at what is the parameter that's taking. Are they speaking about per patient results, per oocyte results, or per transfer results? And what's the multiple pregnancy rate? That is all we should look at. So when we look at mild and minimal stimulation, they have a role, especially in certain patients where there is a very high risk of hyperstimulation and a health disorders. But it comes at a cost of more number of cycles, but with a much higher safety. As we move to the progestin prime stimulation, we use this protocol in the oncology patients, and occasionally some of the patients who are requesting for an antagon protocol with AFC around 9 or 10 with 40 to 50 follicles, where you give the medroxyprogesterone at 10 milligrams per day. Some people give up to 30 milligrams, but we give up to 10 milligrams per day. And the mechanism of action is it blocks the LH surge, and you can't do a fresh cycle in these patients, and it drastically reduces the OHSS, but But there are isolated case reports of OHSs in persistent prime, wherein their inadvertent pregnancy, which was not checked, and then they landed up in hyperstimulation. So persistent prime stimulation is coming into play, and in future it might have a better role, but still it's evolving. Like I discussed, it requires freeze-all transfer, reduces the risk of OHSs. But the most important thing is long-term safety data are limited and no fresh embryo transfers can be done in these patients. If you look at safety and OHS minimization, the current available protocols which drastically reduce hyperstimulation are the Antigone protocol and the progesterone primed ovarian stimulation, where the OHS is drastically reduced. And there, you're not supposed to use HCG if your goal is to minimize it, the trigger, the OHS completely. But when you look at some of the people who do the dual trigger, where they give 1500 units of HCG, depending on the number of antral follicles, and do a fresh transfer. That's also one school of thought. As we move forwards, then the dual and the random start protocol. The dual protocol has come in, but it has come in and has a role, but it has come in a particular situation wherein, if you go back to the original article in which it was published in two journals, both in fertility, sterility, and human reproduction, and I had the opportunity of speaking with Lara Renzi, who was one of the authors. There, the egg pickup cost was not included in 2 times of egg pickup. So there, the cost of cycle in a dual stimulation and dual pickup, the total cost to the patient was borne by the insurance company. But the same thing does not hold good in India. One should look at, if we're doing a dual simulation, are we doing it for the science or the cost? Is the question one should ask for themselves. The random start simulation is being used and the data is becoming encouraging, and more so for the young girl who has an ovarian cancer, and hardly any time, practically 3.5 weeks is what they're giving at the most. And there it's making a difference. But for other patients, dual and random start stimulations are a question mark in terms of the best given chance. When time is short and time limitation is there, and cancer and fertility preservation is there they have a role, but long-term data is needed. Like I discussed, we have to move beyond stimulation protocols, selection of the drug, selection of the dosage, and selection of the protocol. All three play an important role. And we feel, when we say individualization is different from personalization. Individualization is a set of patients with a particular features. In a personalization, that means it's coming at the phenotypic and the genotypic level, where personalized medicine is practiced. Sometimes these words are confusing, and we think when we are individualizing the protocol, we are thinking we are personalizing the protocol. That is some of the confusion we are having in that thing. But when you look at the comparative yield of whatever the protocol is, if you are looking at the per patient, the results are similar. But if you are looking at per pickup, the results are vastly different. It depends on your patient population and the time available and their visits. All make a difference in choosing a protocol. For the poor responders, again, you have two sets of groups. The women who are less than 35 with the same poor number of oocytes have a different outcome compared to a woman with 38 years or 30, 40 years with 4 oocytes. And also remember one important thing. 5 to 10 years back, it was dogmatically said AMH does not change. But the whole concept of AMH is changing. If the woman uses a pill 1 or 2 months before and has an AMH level, the AMH level can get much lower value than what she has up to 2 or 3 months. Similarly, if she has a recent gonadotropin stimulation, her AMH will be much higher. So in a poor responder, use a combination of both AMH and AFC and look at the nomograms before you label them as poor responders, and also individualize them into younger poor responder and older poor responder, because the outcomes are vastly different. And we had the Indian consensus about poor responder and the SRA consensus, but the fact is, at this moment, we do not have an answer of ideal simulation. But the protocol we follow is as follows. We get decent results up to zero point 0.6. Below 0.6 AMH, our results are unpredictable. We also use a combination of antifollicle AMH, and we routinely check testosterone levels. And if the testosterone levels are lower, we supplement them with DHA till the first day of stimulation. Then look at the antral follicles and then do the starting dosage. That is helping us. But for the older PCO, poor responders, say somebody who is 39 to 41 years, we did not find the same benefit of the approach we have taken for younger women. So there is a heterogeneity of the group of poor responders, young poor responders, and older poor responders. What about special population? Here the endomyosis group, the endometriosis group, patients with cancer, patients with SLE, all these patients are coming up. Each patient has individual chance. Optimizing the egg pickup, optimizing the health, optimizing the safety, because in an endometriosis, your accessibility becomes an issue. In endomyosis, your implantation and a coexisting accessibility can be an issue. In some of the collagen disorders, or immunological problems, a high E2 can put them at a multiple risk factor of thrombotic problems. So there, the simulation protocols, what we describe, will be radically different. So a special population protocol, you have to individually raise the protocol. Progesterone only protocol is becoming, and my assessment looking at the literature, will become a major stay in oncofertility. Random start will also play a role in oncology. Dual stimulation, only in another 5 to 10 years, we know whether it will stay or not. And individualized tailored stimulation, be it in the donor, endomyosis, will undergo further refinement. That is what I feel looking at the literature. But the most important thing is the long-term safety of the drugs, except for finding the prions in the urinary HCG, which they detected a decade back, but no health problems were detected. The Cochrane study says about the drugs, long-term safety at this moment looks safe, but how effectively you're using the stimulation in terms of which protocol you're using, it helps you to get a good yield and a good cohort of oocytes is the most important thing. So when you look at the evidence that is available, individualized protocols, there is strong evidence. Mild and minimal stimulation, especially from the Denmark group and the Nugget group, they believe in where the government sponsors the treatment. So the cost per pregnancy is different from the individualized protocol, and progestin and dual stimulation are coming into play. And we should never be carried away by the industrial role, because they only tell you one side of the story, and it's up to us to choose a product based on our society and the guidelines, which will make a huge difference. What's about AI? I mean, I work with staff in the role of various simulation, where we define the pickup of the anti-follicle count, the longitudinal stimulation, follicular monitoring, and at this moment, the integration of AI into stimulation protocol is still very primitive. But in the next 5 years, a lot of difference. The carry home message is, the first thing is, choose an appropriate starting dosage, define your stimulation protocols, which one you want to use it for which patient, and then in failure of patients with poor responders, optional using novel protocols are some of the carry home messages which I wanted to. So the need for continued research, innovation, and education is important, and I acknowledge the sources of the data which I have shown. Most of them are from Lamarca. Second is Dr. Prabhakar from India, who is a close friend, broad brother, the who is a master in stimulation protocol. And all these sources are from human reproduction, human reproductive state, and fertility sterility. Finally, I thank the organizers of ARTfest for giving me an opportunity